Hi everybody, I'm Feeney. Heather asked me to talk a little bit for the annual competencies, and so I thought I would just hit on a few high points of some of the most common things we see in the ICU that I just want to emphasize. So I'm going to be talking about ACLS a little bit, sepsis, ARDS, hypothermia, and anoxic brain injury. So for ACLS, you guys are all familiar with this. I'm not going to spend much time on it. Just remember there's only 3 things you need to remember about any code. You need to do high quality, continuous CPR. You need to shockable rhythms as quickly as possible. And you need to figure out why the patient coded. That's it, okay? In terms of high quality, continuous CPR, you should not be pausing CPR for any reason except to actually deliver the shock and at the beginning for a pulse check, and if they have a question about the rhythm, you may need to pause for a pulse check, though you don't need to do that routinely for VFib once you've checked once and there's still VFib on the screen. How do you know you're doing high quality CPR? Well, the ZOL, we're blessed with that, gives you great feedback on depth of compressions, speed, recoil, etc. But the bottom line is, what's the cardiac output? How much blood are you delivering to the brain, to the heart, to the kidneys? And so one thing I see a lot of people not doing is hooking up the end-tidal CO2. So you want to do that early on in the code. If it's not activated already, you want to go to parameters, enable end-tidal CO2, take the wire from the back of the defibrillator and attach a little plastic thing to either the AMBU bag or the ET tube and monitor end-tidal CO2. Because when ventilation is fixed, as it is in CPR, cardiac output is directly reflected in the end-tidal CO2. And you want to keep the end-tidal CO2 over 10, ideally over 20. A normal end-tidal CO2 is 30 to 40, but if you can keep it over 20, you have a great chance of having a good recovery. We had a code here a couple years ago in the cath lab, 7 hours of CPR, and the patient ended up neurologically intact thereafter because he had high-quality CPR throughout that time. End-tidal CO2 was over 20 the entire time. What if it isn't over 20? But the ZOL tells you you're doing CPR adequately. Well, what can you do? You need to perhaps increase the rate of CPR. So instead of being 100 compressions a minute, you go to 120. And we're reprogramming our Lucas to be able to do that. You may want to give the epinephrine every 3 minutes instead of every 3 to 5. You may want to use higher dose epinephrine, 2 milligrams, 5 milligrams instead of 1 milligram. You may want to add vasopressin, which is pH independent, causes constriction of the coronary arteries, and improves coronary artery blood flow irrespective of the pH. And so that's an alternative with epinephrine that you can do, but those are things that you want to do to improve the quality of your CPR as measured by the end-tidal CO2 to make sure you have a good outcome. Okay. I said you want to shockable rhythms as quickly as possible, so this shows you just the survival percentage from the time that it takes to defibrillate. So if you defibrillate in the first minute, 90% success rate. If you wait 10 minutes, you're down to about 2 or 3%. So you want to shockable rhythms as quickly as possible. And that's why when we call a code, we don't do CPR for 2 minutes as we used to. We call a code immediately when we establish unresponsiveness because we want to get the defibrillator there, because if it's a shockable rhythm, we shock them out of it, that could be the end of the code right then and there. This is just an example of good CPR and bad CPR. So the top tracing is the end-tidal CO2. We don't get a continuous graph, we just get a number. But you see on the top tracing, the end-tidal CO2 is 20, and the diastolic blood pressure is 40. That's the other thing I forgot to mention in quality. If you have an ART line in, the diastolic pressure greater than 20 is another goal for CPR. So here's good CPR, diastolic blood pressure 40, and end-tidal CO2 20. Here's bad CPR, end-tidal CO2 is 8, the diastolic blood pressure is 18. Okay, so again, monitor the quality of your CPR to do good CPR. Okay, changing subjects now, I want to talk about acute respiratory distress syndrome because we see so much of that. This is the Berlin definition, which is sort of the newer definition of ARDS. It has to be acute, meaning that there's the clinical insult occurred within 1 week of the ARDS, have to be bilateral infiltrates on the chest x-ray, not explained by heart failure or fluid overload, and you have to have a poor oxygenation. Mild ARDS is a PF ratio between 2 and 300, moderate PF 1 to 200 with peak greater than 5, severe PF less than 100 with a peak greater than 5. How do we treat this? Well, it's very important to use a low tidal volume to help protect the lung. Okay, so we don't want to get over distension of the lungs. So we want a tidal volume between 4 and 8 cc's. We usually shoot for 6 cc's per kilogram of ideal body weight. Sometimes the patients don't like that, and they take bigger breaths because they're not used to taking a small breath. And then you end up with ventilator dysynchrony, and this is one of the reasons why we need to sedate these patients and sometimes paralyze them to assure that they have a low tidal volume, that we're not adding ventilator-induced lung injury to the underlying injury that they have to begin with. We want to keep the pressures down to avoid barotrauma, so this is volume trauma, the low tidal volume, barotrauma, low pressures. We want to keep the peak inspiratory pressure less than 40. We want to keep the plateau pressure less than 30. We want to use a moderate amount of PEEP to keep the alveoli from collapsing completely, called attalec trauma, the repetitive opening and closing of alveoli. And there's many ways to decide what is the optimal PEEP. I won't get into that. Recruitment maneuvers, sometimes we try to open the alveoli and then keep them open with higher levels of PEEP. Somewhat controversial, but we use quite a bit of it in the ICU. I found it very effective in some patients. Inhaled Flolan, or actually we're using Velitro now, which is an inhaled prostacyclin. Because you inhale it, it goes to the open alveoli, improves blood flow to the open alveoli, decreases the shunt. Paralysis, so if you can't give the patient more oxygen, reduce the amount of oxygen they're using by paralyzing them and get them in sync in the ventilator, paralysis. And then proning, which has turned out to be a huge thing for the COVID epidemic. Patients do very well with proning, definitely improves oxygenation. And if all of that fails, we think about extracorporeal membrane oxygenation, ECMO, but that has to be initiated within 7 days of the onset of ARDS. So something you want to think about really for the very severe cases who are not responding early on. Sepsis, I'm just going to say a few words about sepsis, just to remind people of the definition that the Third International Consensus Conference on Sepsis in 2016 eliminated sepsis syndrome, septicemia, severe sepsis, and defined sepsis as a life-threatening organ dysfunction due to a dysregulated host response to infection. Okay, so that's the definition. When you think you have a patient who has septic, and some people use the old SIRS criteria, in ICU you're supposed to use SOFA criteria, score of 2 or more, or change of 2 or more, not on the floor at Q SOFA, whatever. You think a patient is septic. The key to managing this is our mnemonic AVPES, okay? A stands for antibiotics. The single most important thing for getting a patient better in sepsis is giving appropriate antibiotics. And the mortality increases about 1% for every 15 minutes that you don't give appropriate antibiotics for a patient in septic shock. So hanging the antibiotics is critical. So if you're giving vancomycin and zosyn, which one goes first? The zosyn, because it goes in quickly, okay, you can push it right in, it has much broader coverage. The vancomycin has to be administered over an hour, has much more narrow coverage. So you want to get the antibiotics on board ASAP. Volume, we want to replace the intravascular volume. There's a relative hypovolemia early on in sepsis. We want to give at least 30 cc's per kilogram of ideal body weight of fluid. So that'd be about 2 liters of normal saline or lactated ringers, unless the patient is obviously already volume overloaded. Pressors or pressure, we want to keep the MAP greater than 65. And organ perfusion. Are we perfusing the organs? So we want to follow urine output, mentation, lactic acid level, SVO2, okay, and are we adequately perfusing? So we got to get the pressure up, we got to give enough volume, and if that isn't enough, we consider inotropes actually to increase contractility to improve forward flow, and we follow end organ perfusion to see what we're doing. So we give dobutamine fixed 5, 10, 15, 20, following lactate level, SVO2, urine output, blood pressure, mentation, skin color, etc., to make sure we have end organ perfusion. And then the last thing is ask for source control. If the patient has necrotizing fasciitis, if they have an empyema, if they have an abscess, if they have an infected device, they're not going to get better without removal of those things. So always think of source control. Am I missing something here? A perinephric abscess, an empyema, etc., and look for that. I want to talk about out-of-hospital cardiac arrests. Our #1 diagnosis in the ICU at Highland is post-cardiac arrest. And so this is something we do a lot of, so I'm going to talk a few points about this. I'm just going to give you a little bit of an overview of out-of-hospital cardiac arrest. So this is the CARES registry. This is 2015, but the 2018 data looks very similar. So overall, all people have a cardiac arrest. Your chances of survival to hospital discharge about 10%. and survival with a good neurologic function, 8%, 8.8%. So right off the bat, things are not looking good. So when I talk to families of people that have had a cardiac arrest, I start out saying, this is not good, okay? And it's too early to tell for sure, but it's not good. Notice if you come from a nursing home, it's only 2.2%, so just a terrible prognosis. Shockable rhythms do much better, almost 30%, but non-shockable rhythms, 6%, okay? So, and good neurological outcome, only 4%. And just as just a nice little sort of overview, we're in the ICU, we're in the hospital, we just look at the hospital end of it, but what is sort of the national picture here? Well, there's 81,000 non-traumatic cardiac arrests, about 32% of them get bystander CPR, some places like Seattle much better than that, and then it takes about 7.5 minutes usually for the ambulance to get to the hospital, and then about 20-some percent survive to hospital admission, but only about 10% survive to hospital discharge. So it's that 10% that we're dealing with mostly in the ICU. And I'll talk a little bit about prognosis in just a second. So this is our algorithm in the ER when someone comes in with a cardiac arrest. So any rhythm, whatever they have, do we get sustained return of spontaneous circulation for more than 20 minutes, and is the patient unresponsive, a GCS of less than 8? When we get an EKG, if the patient has ST segment elevation, they go to the cath lab. If they don't, we do a CT head. If they have a large bleed or stroke, we just do supportive care. Otherwise, we consider a PE. If it's positive, then we consider lytics, depending on the size and location of the PE. And if it's negative, then we're going to make sure they're not pregnant, and then we're going to initiate hypothermia, because hypothermia can improve neurological outcomes. And I just wanted, we redid our hypothermia protocol recently, so I just want to remind people that there's 2 levels of temperature that we use. So for a witnessed VTAC or VFib, that has the best chance of good survival and the best documented response to hypothermia. So for those people, we're going to go to a temperature of 33 to 34 degrees. And that's going to delay our prognosis when we go to the neuro exams by at least 3 days. That's going to affect their blood pressure, the coagulation, so a lot of downsides to that. So for everybody else, we go to 35.5 to 36.5, which is much easier to manage, and so that's for everybody else. And then we have a whole protocol with inclusion criteria and exclusion criteria, and you can find that on the AHS intranet, divisions, critical care, TTM, hypothermia protocol. Anoxic brain injury, someone who's had a cardiac arrest and then has not woken up, we use hypothermia because, again, that's the best treatment that we have. But the families always want to know, is he going to wake up? And that's sort of the key issue. So we have a whole protocol that's based on a recommendation from the American Neurology Association on the multimodal prognostication for anoxic brain injury. So at initial presentation in the ER, we want a complete neuro exam, and especially the big 3, pupillary response, Dahl's eyes, and corneals, okay? And we would like that before they start sedation, paralysis, hypothermia, etc. We usually get an EEG in the first 12 to 24 hours, even on hypothermia and on sedation, and here we're looking for seizures, okay? Status epilepticus, occult status epilepticus. Then at 24 hours, we get a neuron-specific enolase, which is a blood test of a brain protein that is released with brain injury. And so people argue about what level of this. Initially they said 33, and then they said 80, 88. But generally speaking, the higher that is, the worse prognosis the patient has. And we do a neurological exam. We do serial neurological exams over time to see is the patient getting better or getting worse. At 48 hours, we do another EEG, this one off sedation, and here we're looking for reactivity. So does the patient react to external stimuli? And we have a whole protocol where they shine bright lights in their eyes, they clap very loud, they squeeze the trapezius, and is there any reflection in the cerebral cortex that the person recognizes this stimulus? So reactivity, very important. And also some EEG patterns are very helpful in terms of prognosis. So burst suppression, for example, isoelectric, very bad EEGs. We also do a second neuron-specific enolase, another neurological exam, and then at 72 hours, depending on everything else, we may do an MRI looking to see if we can see the extent of neurological injury. So we put all this together. What was the initial rhythm? What was the downtime? So we need the ambulance report from the time the patient collapsed until the time of return of spontaneous circulation. What were the patient's underlying medical problems to begin with? What was the neuro exam on admission? How did the neuro exam progress? What's the neuron-specific enolase? What did the EEG show? What did the MRI show? And we put all that together. And if you put all of those things together, you get a very good prognosis of how the patient's going to do in the future. It's not never 100%, but it's very good. And we use that in conjunction with the family's expression of what the patient would want to help decide where to go from there. So anyway, I just wanted to hit a few highlights of some of the things that we see very commonly in the ICU, things that stand out to me. So hopefully if you have any questions, I will be able to answer them for you. Thank you very much.